Hello everyone, let us have an overview of diagnostic stewardship. What is diagnostic stewardship? Diagnostic stewardship is a coordinated guidance and interventions to improve appropriate use of microbiological diagnostics to guide therapeutic decisions. Diagnostic stewardship should promote appropriate timely diagnostic testing, including specimen collection and pathogen identification, and accurate timely reporting of results to guide patient treatment. The appropriate use of laboratory testing to guide patient management in order to optimize clinical outcomes and limit the spread of antimicrobial resistance. It should not be confused with the cost-effective use of laboratory tests, which although a part of diagnostic stewardship, however, it is more limited in scope. To simplify, diagnostic stewardship is right test, right patient, right time, right collection, right container, right transport time, right testing procedure, right report, and right interpretation. It is testing when required and not testing when not needed. This is how the relationship is there between individual care and surveillance data in diagnostic stewardship. The relationship between laboratory results generated from individual patient care and surveillance data, which are used to inform empirical treatment recommendations and antimicrobial resistance control strategies, including infection prevention and control. From the clinical team, the patient specimen reaches the lab team. From the lab team, the results are provided to the clinical team for the patient management. The results are analyzed by the surveillance team, and the analyzed data is shared with the national surveillance system. Also, the analyzed data is used to frame strategies, prepare and formulate policies, which is shared with the clinical team. Now, what is the goals of diagnostic stewardship? The goals include choosing the right test for the right patient, generating accurate clinical relevant results, and right time to optimally influence clinical care. It is, in simple words, judicious use of testing. While antimicrobial stewardship is pharmacy-centric or more directed towards rational use of antibiotics, diagnostic stewardship is more directed towards judicious use of testings. The objectives of microbial, it is like a microbiological stewardship, and the objectives are to deliver safe, effective, and efficient patient care, guided by accurate and timely diagnostic results, including antimicrobial susceptible data. Objectives include to contribute accurate and representative AMR surveillance data, to develop strategies, treatment guidelines, and AMR control strategies, including infection control. Now, let's see what are the challenges for diagnostic stewardship. Over-testing when test is not indicated, that is, routine blood cultures from all ICU patients. Then wrong test ordered, for example, stool culture in patient presenting with watery diarrhea. Then wrong timings, single viral test for typhoid in first week of illness. Then wrong samples, Foley's catheter tips are sent for diagnosing catheter-associated urinary infections. Then wrong transport methods, CSO sample is sent after overnight refrigeration. Then under testing when test is required. That when fever, for example, fever with red flag signs and the testing is not done. So these are the various diagnostic challenges that is encountered while implementing diagnostic stewardship. What is the impact of such unnecessary testings? Physical or psychological harm, then waste of the health system resources, then increased waiting time for other patients, and unnecessary treatment. Physical or psychological harm may occur because of false positive results, wastage of the resources because of the repeated TLC, DLC, and other such tests every day. Increased waiting time, for example, urine cultures unnecessarily with investigated can increase the waiting time. Unnecessary treatment, if a culture comes positive of such unnecessary cultures, then unnecessary treatment is initiated. So these are the impacts of unnecessary. And choose the right test. While considering the testings, consider if there is the test indicated. If the timing of the test is corroborative with the clinical condition of patient. What is the turnaround time? Will the test result influence the care of the patient? Are the criteria available for interpretation of the results? Then which specimen to be collected? How to transport the specimen? There is a Cochrane aphorism which states that before ordering a test, what will you do with the report if it is positive or negative? If both answers are same, don't do the test. Then choose the right test. Patient present with the clinical signs and symptoms. Clinician does the history and physical examination. Now, based on the examination, if it is a high or low certainty, then no further tests are done. But if there is an intermediate certainty, then order the right test, and when the test is positive, rule in the diagnosis. Based on harms to benefits ratio, if the harms is more than the benefits, do nothing. But if the benefits are more than harms, then start the treatment immediately. If the tests are negative, then rule out the diagnosis and consider other diagnosis. So this is how the pathway of the diagnostics takes place during a patient care. What do you understand by right test? Right test means the test performance. In terms of the test performance, the sensitivity should be high, which will yield true positives, and specificity should be high, which will yield true negatives. Technology training is required, hands-on time experience is required for the technicians, and it should fit with the lab workflow. Now, what is right timing? For example, specimen collection. Timing of the specimen collection influences the test results. Poor to no yield if specimen is there, if specimen is sent for culture after antibiotics are administered. Vital is seen in the first week. It's wasteful as antibodies start appearing after first week of illness. Then IgM antibody detection in the first 3 days of fever. So that are the examples of wrong timings of the testings. Then report retrieval. Turnaround time is long, timely communication is not done, then critical alerts are not provided, can impact the patient care. Now, what is right sample? Right sample means which are collected under aseptic precautions, right amount, then in the right container, then right labeling of the container is done, or the sample is done. That collection technique is uh, 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 used for collecting the samples. Then right transport mechanism is employed for the sample. Then right storage is done. For example, CSF should not be refrigerated for culture samples. So that was about the right testing, right time, and right sampling. So diagnostic pathway starts as the patient present in the hospital. The clinical judgment always overrides any lab diagnosis. So no test can replace thorough history taking and clinical examination. So this is how the relation is there between diagnostic stewardship and antimicrobial stewardship. So this is how I mentioned before, the samples from the clinical team reaches the lab team, and from the lab team the results are provided to the clinical team. And in this chain from the patient to the clinical team, and then the samples to the lab team and the results to the clinical team, and in this cycle there is an interchange of data, and this data is analyzed by the surveillance team, and the data is analyzed data is provided to is used to to generate guidelines, protocols, and policies for the healthcare setting. When a patient presents with an infectious disease, the clinician must decide on the appropriate diagnostic tool to be used, including which specimen to correct for analysis, and should be aware of the correct handling procedures. Local guidelines and standard operating procedures must include clear case definitions for sampling. Specimen collection should take place before initiating any treatment. In the case of serious life-threatening infection, microbiology sampling should be done before initiating antibiotic treatment, whenever possible, but treatment should not be delayed while waiting for the diagnostic results. So this is an example of how the sample test request looks like. The sample test request form should include details such as ward or OT or department of the clinical area, the patient diagnosis, the medical history, the referrals from the doctor, the antimicrobial therapy initiated, the name of the collector, the type of wound, and the date and time of the sample collector. That's all. We'll move to the next session. Thank you.